Dear friends and colleagues of the EPMM, I am Frederik Froen from the Norwegian Institute of Public Health, working in the Global Health Cluster, specifically on digital health information systems and e-registries. I've been invited to talk about this construct 2.2 about information systems linking the mother and baby, and thus preserving the information of a key concept of EPMM, the mother and baby dyad. This construct is new, and we've also been instructed to be aspirational for the goals of EPMM. When we state that we are aspirational in the context of information systems, we must assume that we will not be monitoring and supporting the perpetuation of burdensome and unhelpful manual paper systems. So my discussion relates to digital information systems. So this construct requires a linkage of birth and deaths to include causes of death. In this formulation that has been developed during EPMM phase 2, we start with the same concept of linking births and deaths for recording causes of death, but also going far beyond this restricted health information perspective and requesting more linked data for monitoring on health and mortality. And we'll start by deconstructing this construct to understand really what are we supposed to measure under this construct. Firstly, the construct suggests measuring whether such an information system exists. I'll get back to why yes or no is neither useful or aspirational in terms of measuring a digital health information system. But I'd like you now to follow me in exploring what data this construct is requesting, where that data is generated, what it takes to get it together, and how the data that we're trying to measure can generate meaningful indicators supporting the overall goals of EPMM. The first part of this formulation might seem as quite simple. It requests that system can record and report on ICD-PM, which requires both maternal and perinatal conditions to be linked to each death. And this part belongs squarely in civil registration and vital statistics systems, recording specifically birth, death, and causes of death. The next part of this formulation, however, is far from CRVS. It requests data for statistics and monitoring of reproductive health and mortality that reflects this mother-baby dyad. Characteristics, conditions, and events in maternal health and death linked to the characteristics, conditions, and events of the baby's birth, health, and death. This is the health information system, one that traditionally would be organized as a health registry of systematic, longitudinal, and uniform data. So whether we discuss CRVS systems or health information systems, the core of this construct is the linking of the mother-baby dyad and the production of data. In this context, we must remember that there are other constructs in this phase 2, specifically looking at CRVS, about the coverage of birth and death registration, the coverage of maternal and newborn cause of death registration, and also the use of data by health workers. And we should here specifically look at the unique features of this construct. The information we're looking for originates from this continuity in sexual and reproductive health and care, and in relation to perinatal and mortality, particularly through pregnancy, birth, and postpartum or newborn life. The healthcare systems document this information and generate data in the health records for each woman or baby throughout the continuity of care. Traditionally, this is done on paper and then manually aggregated, which destroys any possibility to link mothers and babies before being digitized into typically DHIS2. So the systems this construct is there to promote and monitor are digitizing individual level records so that linkage is possible. An increasing number of countries are implementing such systems. some only as individual level reporting systems, but more often as clinical health records to create this information flow needed for safe and efficient continuity of care, and to offer digital health interventions for maternal and child health supported by the new WHO guidelines. That again means that such systems also has significant potential to support many other EPMM key themes and phase 1 indicators, such as accountable universal health coverage of quality care for all mothers and newborns. The weakness of these health information systems of individual records in terms of the statistics that is being requested is that they only capture clients who attend the public health system. So even though you can get very strong estimates of how many births you have in your community, for example, by combining the number of documented women with either a delivery, obviously, or an antenatal care visit after 28 weeks, or perceived postpartum or received postpartum care, or a baby presented for care or immunization, you still have no complete population denominator for birth. And in terms of maternal deaths, a mother that dies outside a health facility can easily go undocumented in the health information system. This brings us to the other system of interest under this construct, the CRVS. There is a massive underreporting of maternal death for lack of capability, opportunity, or motivation, and linking a date of birth of a child to the date of death of the mother will identify unreported cases, or at least a portion of them, and hence this construct. The obvious weakness is the equally massive underreporting of stillbirth and birth followed by neonatal death, which both are closely associated with maternal mortality. And, not any less important, the lack of data on the key characteristic of maternity, pregnancies. All this being data typically well preserved in the individual health records, or hidden there in plain sight. For example, a mother documented to have had a delivery, but no file or vital status existing for the baby. So in sum, to get what this construct aims for, the full population data on health, birth, and death linked between the mother and baby, you need linked data between CRVS and the health information system, which again internally links the mother and baby, birth and death. And this represents the barriers and opportunities in data linkage across the two aspects of the construct. Health information systems and CRVS operate in two different silos, typically under different ownership and different legislation. The CRVS sector can be in the Ministry of Interior, or Finance, or any independent governmental body. The digital health record is under the Ministry of Health typically, governed by privacy laws for sensitive health information of which only legally required items can and should be shared with external systems such as CRVS or Registry for Statistics. The opportunities on the left, what they have in common, they both rely on unique identifiers in some form or the other. In some settings, the health system and the CRVS share UIDs. In other words, both use a national ID scheme, but others have specific health IDs from national insurance systems, social security systems, or they use systems-generated IDs from multiple simple identifiers or from biometrics. The linkage we're asking for in this construct is therefore not restricted to functionalities within health information systems or within CRVS, but also between them. Unfortunately, this construct is not asking for anything new or unseen. There is nothing unique to this. Throughout the world of digital health, there are numerous data sources that need to exchange information, while under no circumstance the system should share all their content, and solutions to overcome such silos is exactly how digital health infrastructures are being developed and maturing worldwide. The most widely adopted open source approach in our priority countries is the Open Health Information Exchange Framework. It contains centralized registers, including separate registers of clients and registers of shared health records, allowing external systems to deliver or receive pre-specified data points through an interoperability layer that authenticates the external system user, matches the entity or the UID for the pre-specified data points, and then interlinks the appropriate registries with the external source. With both CRVS systems and digital health records in maternal and child health designed to interoperate in such a framework, the linkages requested for this construct is a fully feasible solution. So what is the state of measurement for something like this? As I mentioned, coverage of birth, death, and causes of death in ICD-PM and ICD-MM is in other constructs in this phase 2. In terms of measurements for CRVS and identities, I would say that this is a domain that is well served. CRVS and identities are identified in 3 SDG targets. There are 8 SDG targets that require mortality and cause of death data, and there are 67 SDG core indicators that need CRVS data. There are multiple global initiatives for monitoring the progress of the development of CRVS. When it comes to the health information systems and the registries, the clinical systems that the care providers need, this is typically an underserved domain of measurements. The typical assessments are self-assessment tools by the health metric networks, WHO, and others. These are typically broad assessments. They look at governance, maturity, coverage, quality, timeliness, but it is never just a yes or no question. Do you have a health information system? There is also a WHO assessment tool, which is quite new, called the HISPICS. I still have not seen it in use by any monitoring unit. In terms of the specific construct that we've been asked to look at, the integration of CRVS and health information systems to link the mother and baby in maternal and child health is clearly unserved. There has been an initiative led by UNICEF where we are expecting an upcoming monitoring tool to look specifically at this, but I have not seen it yet. In terms of measuring this construct, again, health information system linked with CRVS that links maternal and newborn health data. Would it be valid? I've already said I believe that measuring the presence as yes or no would be an extremely unclear measurement. Measuring the governance, maturity, effectiveness, coverage, and making full assessments of health information systems will become unclear and probably not feasible. The coverage of the actual data that we're looking for that can uniquely be presented by such a health information system seems to me to be clear, at least at the face value. Let me give you one quick example of what I mean. If you ask for the proportion of any CRVS registered entity, for example, birth, you ask for the proportion of birth disaggregated by any neonatal status, so health status of the newborn, for example, vital status in stillbirth, live birth, neonatal death. You ask for the proportion of stillbirth, live birth, and neonatal death with any maternal condition in pregnancy. This could be, for example, the proportion of live birth and stillbirth in which the mother had preeclampsia, eclampsia, severe or moderate hypertension in pregnancy. If you do not have a health information systems that can link the maternal and child data and can capture the records in CRVS, there will be no effort in creating this data set because it will be impossible. If the system is fully implemented, there will be little effort as this would be an automated report. And I would like to emphasize that supporting the development of such digital health records for the care provider can substantially reduce the reporting burden that they have today. UNICEF has estimated that the care providers already spend 1/3 of their working time on collecting and reporting data. I believe that in terms of harmonization, this would strongly complement existing efforts across the EPMM key themes. It is highly relevant as an indicator that would also support the mortality data with data on coverage and quality of care and outcomes. There is evidence that these systems can add significantly in improving maternal health. I don't find it difficult to interpret what such an indicator would show, and it would point to areas of improvement that could advance strategic planning, policy, and programming at different levels of the system. So I thank you for your attention, and I wish us and you all best of luck in developing such indicators to capture the diet of the mother and baby. Thank you.